and we'll get going today. I'm Dr. Cheryl Parker. I'm the president of the American Nursing Informatics Association, and I am so pleased today to be joined by Dr. Patty Sengstack and Miss Karen Hughart of the Vanderbilt University Medical Center, and they are here to share their real-time stories with all informatics nurses out there and the rest of our community on what they're doing about the COVID crisis. So welcome you two. It's so great to have y'all here. And I just want to jump right into the first question because I know you've got lots on your plate. So let's talk about documentation reduction and configuration changes in the EHR. What have y'all been up to?
Okay, so first of all, Cheryl, 1,000 thank yous for having us on, because one of the things we've been experiencing is a lot of people are looking for some guidance on this. You know, with some of the connections I have through students, former students, some of my work with ANIA, people have been reaching out and have been asking, you know, what is everybody doing? And people are doing all kinds of different things across the country. And we just need to not keep recreating the wheel here and share what we're doing. So today, Karen and I would like to share what we've been doing at Vanderbilt, and we will be giving the tools that we've been using. It's actually a SOP, standard operating procedure for reduced documentation during a crisis. We're going to be giving that to Cheryl, Dr. Parker. Should I call you Dr. Parker?
Oh, please, no. I'm just Cheryl.
So we're going to be providing those to ANIA so that ANIA can share those with you as well. So to start out, we had a chief nurse executive that had a real vision about 6 weeks ago that said, we don't know where this is going, but there's a good chance we're going to be having issues with staffing, to the point that our nurses are going to need to really spend time with the patients and not a lot of time at the computer. So can you start to think about how you would create a SOP policy procedure, something that really documents that? So Karen and I put something together. We ended up sharing that with, we're an Epic shop, so we ended up sharing that with our Epic partners. And I believe they shared that too with other organizations. Since then, we've been inundated. So this is really kind of I always say this is a little self-serving, because we've had to field so many calls. We're like, let's just do it and, you know, tell everybody about it so that everybody has this information. So we've been fielding calls about what people are doing. And so a lot of them have taken what we have provided and have modified it and customized it for them. And we want you to do that. Please do. So what we've done, and I'm going to let Karen talk about this in some more detail, but we created this SOP that really provides what we're going to do when we have determined that we are in a crisis or an emergency situation. At Vanderbilt, we have not flipped the switch yet to start to use this. But I think we're about a couple of weeks behind where New York is. So we're kind of anticipating getting there very soon. So we have this SOP that we've documented for, Karen, correct me if I'm wrong, it's for the emergency department, it's for the inpatient, including ICU, as well as our ambulatory settings where nursing documentation takes place. So can you give us kind of a high level rundown of what's in there?
Patty and I are fortunate enough to have a great nursing informatics governance group that we work with at Vanderbilt. And so one of the first things that we did was get some input from actual bedside nurses about what they were interested in. One of the things that we were thinking about at the time was, let's create a different flow sheet or a different screen in Epic for people to chart on during this crisis mode. And turn it on just when we need it and turn it off later. And when we introduced that idea to bedside nurses, they said, oh, no, 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 no. The last thing we want to do if we're having to float to a different unit, take care of a different population than we're used to, is have to also learn a new computer application or a new workflow, please just let us keep using the tools that we're used to. We know how to navigate them efficiently, but take away some of the requirements. And so that's how we started. We made some assumptions from the beginning, and one of the ones that I keep coming back to every time I have a chance to be on my soapbox is we really focused big time on we are not doing anything to change our standard of care. The only thing we're looking at is reducing our documentation requirements. And so we've tried to hammer that key point in over and over again to different audiences to say, we still expect people to deliver the same standard of care that we always do. We're just saying there are now some exceptions to when you have to document about that care that you're delivering. So as Patty said, we developed this standard operating procedure. The one that we will probably activate first is the one for inpatient areas. So I'll start with that. It basically covers what would be the requirements for documentation on admission of the patient, beginning of the shift, any ongoing reassessment requirements, what to document at the end of the shift, including what we would modify about the way that we document the care plan. After we did the original version, we took it to our governance group, it got approved, and then a work group that was included some managers and some frontline nurses was convened to take this document and talk about how they would operationalize it. And from that feedback, we actually had to go back and do a different version of the document because there were some things, some assumptions that we made that they felt like needed to be really spelled out more clearly so that it would be a tool they could really follow. And so the version that we will be publishing is now finalized. It's been approved by the governance group the second time. The only thing that's not on the document that we have today is our CENO's signature, but it is going out to her to sign today. So I feel pretty comfortable that the one that we will be making available to people is the most current one. Patty, should I talk about the security changes now or save that?
Yeah, no, I just want to make a comment about the process. So I think that using the vetting process that took place was really important and should be underscored. I think if, you know, Karen and I sat in our offices and wrote this SOP and said, okay, everybody do it, it would be really, it would be quite a challenge. But I think the fact that we took it around to all of the key stakeholders and the key groups that need to weigh in on it and help us to tweak it and make it a realistic document, I think was very valuable. And I think it's something that we would recommend to all of you thinking about taking this document and making it your own, taking it out to the people that have to implement it, including your, you know, risk management folks, was incredibly important.
Yeah.
I just wanted to make that point. Yeah.
Yeah, we did include our quality resource people that work with us a lot on our nursing governance group to make sure that they looked at it from their quality perspective. They're the ones that work with our regulators and other folks. And so that was a helpful group to include as well.
Yeah, and that brings me to one of the questions that was submitted on Facebook from actually a colleague of mine, a peer DNP student. Liz Pratt asked about reducing documentation and concerns about regulatory agencies. I have some news hot off the press. Just before I came on this call, I was on the phone with the Joint Commission, one of their nurse executives. And the first question I asked them was, are you still conducting surveys during this time? And they said, nope, they are not surveying now until May, and then they'll reevaluate. So no in-person surveys until May in person. She did share that they are doing a very few handful of virtual initial accreditations for some smaller places, but for the most part, there's no surveying happening in May until May. They are developing a set of FAQs to answer some of the questions that I know all of us have had about documentation. They're going to be posting them on the website either later today or on Monday. So they'll be hot off the press in terms of, you know, what should be documented or what can we reduce during this time. I submitted to her our SOP. She said, you're right on point. They are agreeing with the documentation by exception strategy, which is, I know, Karen, sometimes you call what we did documentation by exception on steroids, right? I mean, we really, when I think about it, it really is on admission, you know, kind of, why are you here? I'm certainly I'm trying to remember some of it, so help me out.
Yeah, we definitely included all the infection control screening, and we've got a new COVID screening. We felt it was very important because of the risk that anybody coming in our doors could be a potential risk. We wanted to make sure that we called those out as things that needed to be documented, because we're tracking all that on a dashboard that the organization's dependent on. So that would be an example of something that we would require documentation of, even if it's negative. A lot of other things, the standard is that you document only abnormals, and you would not have to document positive normal findings.
So again, to be on your soapbox, Karen, even though the assessment has taken place, we're only expecting documentation unless there's something that's kind of outside the normal limits. I mean, on admission, I think we've scaled it back to vital signs. I mean, they're really critically important things that need to be communicated to the care team. So vital signs, allergies, medications, trying to think of what else is on there, you know, any kind of other conditions or, you know, medical history that's
comorbidities,
why they're there.
Yeah.
What was that, Karen? Sorry.
Yeah, comorbidities that might be applicable to the reason that they're admitted. Yeah. And the other thing that we did was we already, before this SOP, we have our documentation model built on the SABA CCC model. That's our framework. And we already had certain care categories that require documentation beginning of every shift. We basically retained the requirement that we do that we assess all of those systems, so cardiac, respiratory, neuro, et cetera. But again, documenting those assessments by just by exception, what the abnormals. The other thing that we did to operationalize this that is already turned on in our system is we had, through our computer system, cues for the nurses to know what the required documentation elements were, both on admission and for every shift and at discharge. And so we took the SOP, we looked at those required documentation elements, and we created a new set of required documentation for crisis, and turned that on about a week ago, so that people are only cued to document these minimum things when they look at their overdue documentation reports and other triggers in the system that tells you forgot to do something. So that's already scaled back in support of this SOP, even though we haven't actually activated it. So we're in sort of the unique position of saying, I know the computer's only telling you need to document something this frequent, but until the SOP is activated for your unit, we expect you to do documentation to our normal standards. So that's something that will help them, and something that the staff nurses requested.
Right, and that just reemphasizes their desire to, because Karen and I heard this loud and clear, don't give us anything new to learn. You know, let us keep our very familiar workflows. I like to use the analogy of the grocery store. You know, when you have to go to a different grocery store and you can't find anything, you know, it's kind of, don't make us go to a new grocery store. Let us keep our same, you know, workflows. We know where everything is, just reduce what we need to document. And so this configuration.
But the grocery list is shorter. Yeah.
Well, it is in real life too, isn't it? So Cheryl, when I asked the nurse executive from the Joint Commission to send me their FAQs when they're published, either today or Monday, I will make sure those get to you right away so that they can go on to this ANIA site so that people can take a look at it. I was really happy the Joint Commission was extremely on board with, reducing things and cutting back and not surveying. And one of the questions I asked them was, one of the things that people are worried about, and I think this kind of came out in Liz's question on Facebook, was what about when they come to survey, say in the fall, or maybe in the summer, who knows when all this craziness will be over. But then they see that there's this not much documentation in March and April, and where is it? You didn't do it. And if it wasn't documented, it wasn't done. So she said, in their FAQs, we should see this, that they really are not going to be looking at documentation during this time that there is called an official disaster.
Great.
So I think people that are worrying about that need to not worry about it as much. And I think that's kudos to the Joint Commission.
Yeah. One of the other things I would say about that, Patty, is even though the Joint Commission is probably going to cut us some slack, the other people that do closed record reviews would be people like lawyers and folks like that. So one of the things that we did build in the system to address this is that we've got a field in our flow sheets to document when the SOP is activated for a patient and when it's inactivated. So whether it's a patient moving onto a unit that's following the SOP or a patient being admitted to that unit, we would document the time it starts. And then if we get back to our normal staffing model and staffing ratios, we would stop using the protocol and we would document the stop time. That means 20 years from now, if somebody looks at that record, they would have a indication of what period of time this SOP was in effect for.
Mm-hmm. Yes, very good. And then do you also want to touch on, we know that there's going to be some staffing changes, most likely during the really peak times. We have no idea where we will be in terms of having the nurses available to care for patients. So I know a lot of models of nursing care delivery are changing. And also we'll probably see a lot of nurses floating to different places. And so we've done some changes to the system for that. And so Karen, do you want to talk about how
Sure.
we've done some updates to access?
The model.
In fact,
wait, Cheryl has her hand up.
Yeah, I was going to say, just real quickly, one of the questions from Facebook, Jane Childers Morris asked how we can handle emergency EMR training for staff brought in to assist. So I think that's really on people's minds today. Sure. When I get a labor and delivery nurse in ER, sure, what do we do?
And how do we give them access?
Here where we are so far with that. We've had a group from our nursing education and professional development department that's been leading out on this, and the model that we have finally landed on after much discussion is what we're calling a nursing assistant role. So what we anticipate is that a nurse on a unit that can no longer sustain their staffing model and ratios with their normal personnel that would be available to them, that would be fully trained on both the clinical aspects and the information technology used on that unit. They would basically double the nurse to patient ratio and assign another nurse from a different area to partner with that nurse. And so it would be kind of a team nursing model, but the patient would always be assigned to a home department nurse that always works there with that population uses those tools and systems all the time, and then would be supplemented by someone else that could come in. Now they will have to do an assessment to determine, what's the skill set of this extra pair of hands that I'm going to be working with. In some cases, it might be somebody that's able to do a lot of computer documentation and take some of that off of them. But in other cases, it might be somebody that works in the OR that really uses a pretty different computer application, might take them a while to come up to speed on the inpatient application. And so in that case, it may be that they would do more of the physical care, even assessments on the patient that another nurse would, that the main nurse would document. So it would definitely be a partnership. Both nurses would be signed in and identified as caring for that patient assignment that day. So I think there was a question that we got on Facebook about how do you handle the problem of having one person doing the documentation and somebody else that may actually be doing the care. And I think our approach would be that we would have both of those nurses assigned to the patient. And so if you look back at the records, you would be able to see that this is a shared assignment, and that they may be documenting for each other to a certain extent, depending on their various skill sets. To support the training for that, we've done a couple of things. First, we put together from an informatics perspective, sort of a checklist to say, if you're getting a nurse floating to you from these units, they use technology in that area that's very similar to what you use. And so you should just be able to give them the minimum amount of orientation about the differences in the patient population, and they should be successful doing everything in the computer that you would expect. However, if they're floating from a different area, like somebody floating from an operating room to an ICU to be a nurse assistant, they would not be able to handle the same documentation. And so we've done a couple of things for that. First, we've got some job aids and some recommendations. So our recommendation is, don't try to make them skilled up in doing every single thing in the system. Pick the simple, frequent things, like teach them how to document on the INO vital signs flow sheet. Those are things that have to be documented frequently in an ICU. They could catch on to that pretty easily. And it's pretty easy to teach because it's just a flow sheet row, like a spreadsheet. Let them start with that. Don't try to teach them how to do the complicated IV titrations and invasive line monitoring that they're not that they don't have a clinical background for or know how to use the informatics tools that support it. The other thing that we're doing is sort of back to school model. Our nursing education and professional development and our eStar training, our system is called eStar, but our training group that teaches the computer classes have partnered together and have put together some virtual learning opportunities for people to do a sort of a quick and dirty course to, if they already know how to use Epic, but they just don't use the inpatient application, start from what they know and just teach them what they would need to be sort of minimally successful in that inpatient environment. And so they started that this week. We're also putting some surge techs from our OR, since we're having lots of cases canceled right now, elective cases. We're putting some surge techs through our nurse extender training program, try to get them in class for a week and have them fully up and functional by next week. So we're not just looking at the RN workforce, but also the other supportive people that it's going to be required if we double the, I mean, we're putting semi-private rooms in places that have always been private rooms and some strategies like that to try to create capacity. So we're going to have to bring in a lot of, we're hiring 500 nurses right now if we can find them. So trying to get 500 people trained and oriented is pretty daunting if you do it the traditional way. So we've really had to come up with some, what's the bare minimum stuff that people need to know to be successful, along with matching up their competencies with where we place them. I think between those two strategies, that's going to help. We also will have our nursing informaticist on call. We're planning to have some Zoom meetings at the beginning of every shift so that they can be available to answer questions about that they might have about resources that might be available as job aids to help them with this application that might be somewhat less familiar, but not just the main computer charting application, but some of the other technology on the units that might be new for this person, trying to provide some guidance and some job aids for that. So that's a lot of information, but it's been a big multi-group kind of effort to try to get this going.
Our nurse informatics team really rocks. I mean, they are fantastic, and they've been very flexible in doing a lot of different things. One thing I wanted to make sure, and you, Karen, you were probably going to get to this, so correct me if I don't have any of this right, but one of the things we needed to do from a configuration standpoint for our system is to, you know, make sure that the nurses have access to the right, you know, system. So they, what was created was a security template. I think it's called the disaster nurse role. And so every nurse was assigned this as a security template. So, but by default, they go in and their normal security template is there, and that's what they use to go in. So on their home unit, nothing has changed. But they have the opportunity to flip over if they have to get floated to somewhere that they're not typically working in, and they need access from, you know, they're working in ICU and they have to go down to the ED or vice versa. They can go to the disaster nurse role, and that role will then give them the access that they need. So it's kind of a
it's a combination of signing into that security template and picking the new place that they'll be working that day, and they automatically get the right screens, the right tools, etc. So it's worked very well. We've been having to float a lot of nurses to some of the assessment sites that we've got set up in tents and offsite clinics and the garage and places like that, and having this template so it doesn't take an hour to get somebody the right security to function in that new area has been really key to that kind of flexibility.
Yeah. Yes.
That brought up something, a quick question I wanted to throw in here when you were talking about the tents and the garages and everything. I know you're not faced with that yet, but what thoughts are you giving toward maintaining that patient record and that patient identification as they move between maybe facilities or offsite?
I have a fabulous IT team, and they literally took a parking garage that's right outside of the entry to one of our clinical buildings, and in about 48 hours they put up walls, heat, light, network, and it's now an enclosed extra ED space that has WOWs and printers and everything to provide the same care. So our approach has been, to the extent that we can sustain it, to keep using the computer system for all of these patients. Now, there have been some places that hasn't worked. We have seen such a high volume of patients in some of these offsite assessment centers where they do a quick assessment and then test them if they meet testing criteria. Some of those have done so much volume that they haven't had time to document that in the system. And they are using a paper. It's a combination of orders and documentation, all combined into a single document. And then that gets scanned back into the record. So it's certainly not the same thing as having discrete data. Fortunately, we have not had to use that except when we get way over census in some of these offsite assessment clinics. We have not had to resort to that in the inpatient space at all.
Yeah, we hate to admit that we're using some paper, but it kind of, it just, the volumes were just so high.
Yeah.
Just had to do that.
Yeah. And so it does mean a little bit of double documentation if that patient has to get admitted, because they've already probably answered some screening questions that are documented on paper, and we turn around and ask them those same questions over again so that we can capture it for the record. But that was the trade-off, to be able to we've tested more patients in Vanderbilt than the rest of the state of Tennessee put together, and it's because we've got a pretty well organized testing process and assessment process. So that's made that possible.
And Cheryl, when you talked about training, and then let's go back to talk about implementing this new SOP. We certainly don't expect everybody to remember, do I need to document that or do I not need to document that during this time? So one of the other things that was created, and I think we can share that with them because I don't think there's anything proprietary on it. We can share we have these little cheat sheets that can be used to just put up on the workstations that have a really simple list of what needs to be documented according to the SOP. So that's another thing that we can send you to put in the website there.
Yeah, that's excellent.
Yeah.
So anything else about any new care delivery models? Anything else that you guys want to share out there? Because you're kind of in the getting ready for it phase.
Mm-hmm.
The other thing that's come up that might be worth sharing because other people are likely to encounter this same problem. We had a COVID outbreak in one of the area nursing homes a week ago, and about 20 patients and staff were ill and positive, and they needed to empty out that nursing home quickly and get those residents somewhere else. And so at one of our offsite hospitals that we've recently acquired in Wilson County, they accepted 25 of those patients in about 4 hours without any preparation, which increased their census by 50% in 4 hours. So one of the things we did as a result of that is we also developed a standard operating procedure that we can put in place if this happens again. So if any of these other post-acute care facilities or assisted living facilities have an outbreak and they need to move patients that are reasonably healthy, but they need to vacate the premises so they can do a deep cleaning, we've got an SOP of what would be the documentation for that population. It also includes some monitoring if they've been exposed, so that we would continue to monitor them, see if they need to be tested, and then they would kick into the regular patient population. But that's something else that we did based on that experience. And I think based on the news, other places are probably seeing the same kinds of things, unexpected outbreaks in some of these elder care facilities. So we'll send you that SOP as well. It's not quite as far along in the development. It's just now been worked on this week, but we can share what we've got right now.
Well, I really appreciate that, because I think in this unprecedented time, the faster we can share what we're doing, we can hopefully reduce the workload on somebody else. And one question from Kim Alder Scott on Facebook, I thought was a kind of a unique way to wrap this up. Wanted to know the 3 most important or useful things that an informatics team could be doing in areas that are just starting to experience a curve. So you're probably just a little bit ahead of other people and behind others. So you're, and I think as we go along in this series, we keep asking the same question, we're going to learn different things. So from your viewpoint of where you are in Nashville right now, what's going?
So, I think number 1 would be ensuring that your organization has an SOP that addresses, how are you going to deal with the fact that you're just not going to have time to document anything but the minimum. Something in writing, I think, is absolutely important. So we're really hoping, our goal here is that, don't recreate the wheel. Take what we've done and please just and tweak it. So that would be the first thing that I would say. Karen, what else are you thinking?
I anticipate what, especially areas that have nursing informaticist teams, what they can do to partner with their colleagues in nursing education and in the IT department to prepare the workforce. I mean, clearly it's going to take a lot of rethinking about how we use our people resources, bringing people from non-clinical roles back to the bedside.
Mhm.
And so I think anything that we can do to make that easier, to provide people with resources to do that safely, because it's not enough just to give somebody access to the right flow sheet or other computer tool. If they don't know how to use it safely, we have not done anybody a favor. So it really is evaluating what's reasonable that we could do, based on sound adult learning knowledge, and bring people up to speed in areas where that can reasonably be done, and also to kind of put training wheels or brakes around things where they really probably shouldn't go there because they're not going to have the skill set to do it. So I think that's another thing that an informatics nurse can really bring to the table in some of that kind of planning.
And I know we haven't really touched on this, and I don't think we'll have time in this session, but there's been a tremendous amount of work with informatics groups around very quickly implementing telehealth in all shapes and forms. You've probably seen the Office for Civil Rights has published a document that allows people to use really any type of non-public facing communication tools and products. So, I mean, that even means things like Apple's FaceTime, and some of those tools that, I mean, there's a lot of them out there, and they actually have, here's another one I can send to you, Cheryl, that they have an FAQ document about using telehealth and its appropriate use and what you can do and what you can't do, and where HIPAA, there's some leniency around the HIPAA rules for now anyway, on using some of these tools so that the patients can be cared for no matter where they are. I mean, I think it's been wonderful. I know that you correct me if I'm wrong, but I believe you have another interview coming up with one of the CNIOs who's been intimately involved in setting up some quick telehealth work. And so I'm looking forward to hearing what she has to say.
Yep, I'm setting up interviews about as fast as, I mean, people are so willing to share their experiences and their information to get out there. And I think that's probably a wonderful place to end this for today, is to thank you for your willingness to come on, to verbally share your information, and even your video pictures. Yay. I know we don't like to see our own videos. None of us do. I don't either.
I don't either.
But sharing that documentation to hopefully give other people a leg up, because the one thing I'm seeing is we got to be flexible and we've got to be resilient in this period of time. Yep. And that's what nurses do.
Yeah, that's right.
And we need to not do it in silos. So all this sharing is fantastic.
Yeah.
So yes. Cheryl, thank you.
I thank you guys. Patty, it was your original idea. Thank you for reaching out to me. I was so hesitant to go, oh my God, I'd love to do this, but do I ask him? Do I dare? And you're like, yes, please dare.
Let's do it.
I will get this up on the air as fast as I possibly can. And thank you again, ladies. It's been wonderful, and stay safe as you can.
Thank you.
Thank you.